I'm going to introduce. Dr. Jennifer Price earned her medical degree at Johns Hopkins School of Medicine, and continued her medical training there, completing a residency fellowship in GI and gastroenterology and a fellowship in transplant hepatology. She earned her doctorate degree in clinical investigation at Johns Hopkins School of Public Health. She is a fellow of the American College of Physicians, a member of the American College of Gastroenterology, American Gastroenterological Association, and American Association for the Study of Liver Diseases. In her research, Dr. Price addresses liver disease in HIV positive patients and also studies viral hepatitis and non-alcoholic fatty liver disease. So thanks for coming to speak with us about hepatitis C today, Dr. Price.
Okay, thank you, Rena. I'll be, as you just started talking about hepatitis C virus, there's a lot to cover. Here are my disclosures. And here's the outline. I'm going to give a brief background on the natural history of hepatitis C, and then just a overview of what we currently have in our arsenal to treat hepatitis C, and then dive into a few case examples, really highlighting special populations of people living with Hep C. And then at the end, as long as there's time, we'll talk about updates regarding hepatitis C elimination, because there have been some pretty exciting developments recently. So just for some review for you, the natural history of hepatitis C infection is on this slide. When someone is exposed to hepatitis C, there's around a 15 to as high as a 45% chance that they will spontaneously clear the virus, meaning that they will not develop a chronic hepatitis. But most people, particularly most adults who are exposed to hepatitis C, will develop a chronic hepatitis. And then people with chronic hepatitis C can develop chronic inflammation, fibrosis, and eventually cirrhosis of the liver. The risk of that is around 20 to 30% of people living with hepatitis C, which you can see here on the slide. But I just want to draw your attention to the time frame. It usually takes at least a couple decades to develop cirrhosis from the point of acute infection to cirrhosis. And then once cirrhosis is developed, there's around a 1 to 4% risk of hepatocellular carcinoma per year, and up to 5% risk of hepatic decompensation per year. This is in the absence of Hep C treatment. We have identified many different risk factors for disease progression. On the slide here are things that accelerate the natural history of hepatitis C. So these include, as I mentioned, longer duration of infection, but also being older at the time of exposure. Gender or sex does have an influence, as does genetics. Organ transplantation, so we do see a much more rapid progression of fibrosis post-transplant in the absence of treatment, and cirrhosis develops within a decade if Hep C is untreated on average. And then co-infections, hepatitis B and HIV. Some of these, I guess, could be modifiable with antiviral treatment. And then the modifiable risk factors include alcohol use, and then a lot of the metabolic risk factors, so insulin resistance and hepatic steatosis. So this is a schema of the Hep C life cycle, and I'm not going to go into the details in all of this, but if you're interested in a deep dive, there is this website that I included on this slide at the University of Washington. They have actually excellent hepatitis C resources, but they have a great section on the biology and the life cycle of the virus. So I really encourage you to take a look at that. But what I wanted to draw your attention to here is, after binding to the hepatocyte and entering the hepatocyte, when the viral RNA of the hepatitis C is translocated, here in this proteolytic processing section, you can see the different mature Hep C proteins that get cleaved. And I like this slide because it shows you some of our viral targets that we have with our current direct-acting antivirals. So you have the structural proteins here, like the core protein, which helps, which forms the capsid of the virus. And you've got the envelope proteins, but the non-structural proteins over on the right here are the proteins that are really targeted by our current direct-acting antivirals. And you can see their role in the viral life cycle sort of in the next stage in RNA replication. So you'll see the NS3 proteases. This is our target for the protease inhibitors, the NS5A replication complex, and the NS5B. Um, so that sort of takes me to what we currently have approved by the FDA in terms of our direct acting antivirals. So the main categories here are those three that I, pointed out, which are the NS3 protease inhibitors, the NS5A replication complex inhibitors, and then the NS5B. There's two different categories. There's the nukes and the non-nukes. Here in the United States, the one that we use is the nuke inhibitor, the sofosbuvir. And the sort of idea behind treatment is you combine multiple of these DAAs together to achieve hepatitis C cure without resistance. So Hep C therapy has really evolved really dramatically over the past decade. This is when I joined the faculty at UCSF. This is when I was a fellow. So at that time, we just had the first generation protease inhibitors, and they had to be combined with peg interferon and ribavirin. There was just a flurry of activity over the past several years. And now things in terms of drug development have quieted down a bit, and we really have these medications that I have listed on this slide as our current recommended regimens. In particular, the ones that are most commonly used are these top three. And our first line treatments are really these top two. So we've got glecaprevir pabrentasvir, which is a combination of a NS3 protease inhibitor and an NS5A inhibitor. The typical duration for this is 8 weeks, and it's pangenotypic. This is also known as MAVRIT. And then our other pangenotypic regimen that we use for first line treatment for somebody who's treatment naive is sofosbuvir velpatasvir, which is the NS5B inhibitor and the NS5A inhibitor. This is typically 12 weeks duration. We also have the sofosbuvir velpatasvir voxilaprevir. So this is a triple regimen. This includes the NS5B, the NS5A, and the protease inhibitor. And this is typically used for people who have experienced virologic relapse with one of the first line regimens. It also is pangenotypic. So just to remind everybody, when we're treating somebody, the goal of our Hep C treatment is, of course, viral eradication, and we call this sustained virologic response, or SVR. And what this refers to is sustained loss of hepatitis C RNA 12 weeks after the end of treatment. So unlike HIV and unlike hepatitis B, there's no known viral reservoir for hepatitis C. So once it's cleared, it's really cleared, and we can call this a cure. And this is why we're able to take people off of antivirals and achieve the cure. The other goals of treatment, of course, are to prevent disease progression. So there's been multiple studies now showing that achievement of SVR12 is associated with improved quality of life, improvement in fibrosis, decreased cirrhosis, decreased risk of liver cancer, improved survival, and also improvement in the extrahepatic manifestations of hepatitis C. And I just wanted to show you how amazing these medications are. Now, this is the SVR12 on the y-axis. So these are essentially the cure rates. What I'm showing you here is sort of a summary of the registration trials for sofosbuvir velpatasvir or Epclusa. And this is across the genotypes and just these fantastic numbers, close to 100%. Nothing in life is 100%, but when I'm treating somebody, I can expect 95+% chance that they'll be able to be cured. And similarly for glecaprevir pabrentasvir for 8 weeks, this is MAVRIT, again, extremely high cure rates. So in our sort of untreated treatment naive patients who have either no cirrhosis or compensated cirrhosis, really our two main options that we use are either the glipib or the sofel. And I'm often asked, how do you choose between these two? They're both excellent. They haven't been studied head to head, but they both have extremely high SVR rates. When patients ask me what's the best one, I just say, they're both excellent. But there are some nuances that might make you choose one over the other. So for Mavorite, it does have this protease inhibitor, and the protease inhibitors are actually contraindicated in the setting of decompensated cirrhosis. So you wouldn't use it in decompensated cirrhosis, but in compensated cirrhosis, it's safe. Um, and with Epclusa, there is resistance testing recommended in patients who have genotype 3 and have cirrhosis. That's sort of a group that's a little bit harder to cure. And I'll talk a bit more later about the RAS testing, but there is a specific resistance associated substitution associated with genotype 3 that if you have that, plus cirrhosis, there's a little bit lower SVR, chance of SVR with sofosbuvir velpatasvir. It's still very high, but it goes down to like 85%. The Mavorite it's 3 pills a day versus Epclusa, which is 1 pill a day. I think importantly, the 3 pills a day with the Mavorite, it just important to know is it's not 3 times a day. It's 3 pills that you take at the same time every day. But for people that really have a difficulty with pills, that could be an issue. Mavorite also should be taken with food, whereas Epclusa doesn't have a food requirement. The big difference between the two is Mavorite is 8-week duration and Epclusa is 12-week duration. So, some people want to be done sooner. So the 8 weeks is more favorable for them. And then finally, there are drug-drug interactions with these medications. So that could be the deciding factor in choosing one or over the other. The key ones to know about in Epclusa is that we don't like to give it with high dose PPIs because the PPIs can decrease the efficacy. And then there is an absolute contraindication of sofosbuvir, which is one of the components of Epclusa, with amiodarone. It can cause a significant bradycardia. So my practice is, unless there's, one regimen that's clearly contraindicated, like my patient's on amiodarone, I'll just review both of the options with the patient, and then we'll make a decision based on patient preference. And I find that this really helps include the patient in the decision making. And so that's usually where I'll go. Sometimes the insurance will require one or over the other, so I do explain that to the patient as well when we're making this decision. So now I'm going to move on to some special populations. I'm not going to talk about each of these special populations on the slide, but maybe we'll have time after to answer some questions if you have some. But I'll start with decompensated cirrhosis. So this is a 60-year-old man. Hep C cirrhosis has been complicated by variceal bleeding, status post-banding. He's child PUB, his MELD score is 13, and he's genotype 1A. He's treatment naive. So how would you treat his Hep C? Would you give him Epclusa for 12 weeks, soft-vel for 12 weeks, soft plus vel plus ribavirin for 12 weeks, glicapavir, perbrentasvir, or Mavorite for 12 weeks, or the triple regimen, soft-vel Vox or Vosevi for 12 weeks? And I'm not savvy enough to set up an actual question answer ABS system. So I guess I'll give you guys a minute if anybody wants to say it out loud or put it in the chat what your answer is. People are shy. Okay, Gloria, thank you for being brave. Soft plus riba because of cirrhosis. So yeah, so it's not because of cirrhosis, but you're right, because of decompensated cirrhosis, it would be soft vel plus ribavirin. So decompensated cirrhosis, there is a lower likelihood of SVR with just the sofosbuvir velpatasvir alone. So that's why we add the ribavirin. The ribavirin is not a direct acting antiviral, but it does have antiviral properties. We used to use it all the time in combination with pegylated interferon. We don't really use it very much anymore, except in the setting of decompensated cirrhosis or some challenging populations who have experienced DAA failure. The Glycapivir pibrentasvir wouldn't be right because it has the protease inhibitor, and the protease inhibitors are contraindicated in decompensated cirrhosis. And that's the same problem with the voxilavir here. So we're really more limited when somebody has decompensated cirrhosis in terms of your treatment options. So my next question is, what if his hemoglobin is 9 and he has a history of coronary artery disease? And what I'm getting at here is that the ribavirin does have some significant side effects. And one of them is it causes a hemolytic anemia. And so when somebody's already anemic, they don't necessarily have much room to go. And if they have a history of heart disease, for example, we do worry about inducing, an STEMI or demand ischemia if we drop the hemoglobin significantly. There are other contraindications to ribavirin, including pregnancy. Ribavirin is a teratogen. It can also cause mood disturbances and can cause insomnia. So there are recommendations for people who, or there's guidance for people in this scenario who have decompensated cirrhosis, who you should be giving ribavirin but can't, and that's essentially to extend the treatment duration from 12 weeks to 24 weeks. So these are sort of our tricks that we used more before when we didn't have quite as excellent DAAs, which was if somebody was a little bit harder to treat, we would either add ribavirin or extend the duration of treatment or both. So that's really the premise here, is just extending the duration of treatment. So what I'll often tell people who might be borderline about the ribavirin candidacy is I'll say that we could start with ribavirin, we could add ribavirin, try to do the 12 weeks with the ribavirin, but if they have any side effects or aren't able to tolerate it, we could always drop the ribavirin component and then extend the treatment duration. Okay, so now what if the same case, he didn't just have a history of variceal bleeding, but he also had encephalopathy, refractory ascites, and a MELD of 22? Any thoughts about, what you would think about in this case? Connie saying transplant. Yeah, so this is someone that, their MELD is high enough that really you should do a transplant evaluation. We can, if he was not a transplant candidate, we would treat because he's not a transplant candidate, and so we would want to prevent any further decompensation. But this is someone that it might be a little challenging to get through treatment, and also the likelihood that treatment is going to lead to clinically significant improvement in his decompensation is a lot lower. So I would refer for transplant evaluation or start the transplant evaluation process. And then depending on where things are going with the transplant process and how long you may be waiting for transplant, decide on the timing of treatment, either before or after transplant. Okay, so the next special population is treatment failure. So this is a 45-year-old woman. She had genotype 1 hepatitis C, let's say non-cirrhotic, and had viral relapse after Epclusa for 12 weeks. So what do you recommend? Should we do the Epclusa, so sofosbuvir velpatasvir again, but extend the duration to 24 weeks? Should we switch to glycapivir pibrentasvir or Mavorite for 12 weeks? Should we do sofosbuvir velpatasvir, voxilavir, Vosegri for 12 weeks? Or should we check for NS5A resistance associated substitutions or RASes before deciding what we do? If anybody wants to take a shot. All right, I'll tell you the answer for this one. And that is you would use sofosbuvir, velpatasvir, boxilactivir, also known as Wasabi, for 12 weeks. A lot of people want to check the RASes, but it actually doesn't affect your decision making, so you don't need to check the RASes. Um, so our recommendations, this is just kind of pulled from our guidance website, but our recommendations for people with treatment failure, either with or without compensated cirrhosis, depends a little bit on what the prior treatment exposure was. If it was a sofosbuvir-based regimen, like the patient in the STEM, then the preferred treatment would be the Softel-Vox for 12 weeks. If the person had genotype 3 and cirrhosis, then we would also add on the ribavirin. Um, the alternative regimen could be glucapavir, probentasvir, or Mavyret, but the duration for that is 16 weeks. If someone is a glipib or Mavyret treatment failure, then there are two preferred regimens. One is to repeat with Mavyret and add sofosbuvir and ribavirin, but that's 16 weeks, and it is kind of, it's a lot. Or do the Softel-Vox and add on ribavirin if the patient has cirrhosis. So basically, the Softel-Vox is a good option for the patients who can take a PI who have experienced treatment failure. There are some scenarios where you have people who have failed multiple treatments, including Softel-Vox. And in those cases, the two recommended treatments are here. You could try Softel-Vox again with ribavirin, but that's 24 weeks. Or you could try glucapavir, probentasvir, so the Mavyret plus sofosbuvir plus ribavirin for 16 to 24 weeks. This is the one that we typically tend to do. We'll do the glipib with with ribavirin. And we've looked at a case series. I mean, it's not very common that we see these multiple DAA treatment failures anymore, thankfully, but in a case series of over a dozen between us at UCSF and Kaiser, Northern California, everybody that we treated with this regimen actually achieved cure. So I did want to just talk briefly about the RASes because this does come up a lot. What are they and what do you do about them? So Hep C RNA replicates very, very rapidly. So by chance, replication errors are going to produce these resistance-associated substitutions at baseline. And then these resistance-associated substitution or RAS variants could be selected for with treatment failure. So they could lead to virologic breakthrough on treatment, but that is very rare. But the more common thing would be that they would lead to a relapse. And the potential for RASes really depends on a variety of things, including, what genotype somebody has, and also the barrier of individual drugs. So sofosbuvir has a really high barrier, so we typically do not worry about sofosbuvir resistance. The protease inhibitors, it depends on the generation. The earlier generations had a lower barrier. The NS5A inhibitors also have a lower barrier. But in general, if we combine these different drug classes, we can mitigate the selection of RASes. So we used to have to rely on RAS testing a lot more, but now that we have the current regimens that we have, we really don't need to do RAS testing, except in some very rare situations. And the main situation is in patients that have, like I said before, cirrhosis and genotype 3, and you want to use sofosbuvir or velpatasvir. There is this one mutation, Y93H, which only occurs in a minority of people, is only prevalent, I would say, in a minority of people with genotype 3. So it's only a potential issue for those individuals. And this is just sort of a schema for you to kind of visualize these RASes. So the idea is that, at baseline, the predominant virus does not have a RAS and is sensitive to the antiviral therapy, but you might have a small proportion of the circulating virus that is resistant. And then with antiviral therapy, you sort of eliminate the sensitive virus and you sort of select for the resistant virus. The issue is most of these resistant viruses are often unfit, so they're only present in a very low proportion. And so they can be undetectable prior to therapy. But like I said, usually you don't have to check RASes. It's just that one specific scenario. There are some times when we'll do it, on a case by case basis. So people that have been in my clinic will appreciate this. So if you're not sure if somebody really has treatment exposure, they're not sure if they finished their treatment, is this a treatment failure, or were they not treated, or is it a new infection? Maybe RAS testing would be helpful, but that's not in our guidelines. Okay, next special population I want to talk about was pregnancy. So you're seeing a 30-year-old woman who was diagnosed with Hep C during a routine Hep C screening in pregnancy. Which of these do you advise her? Hep C is associated with a higher risk of intrahepatic cholestasis of pregnancy. The risk of Hep C transmission to the infant is 25 to 30%. The DAAs or Hep C treatment is contraindicated during pregnancy, and or she should avoid breastfeeding to reduce the risk of hepatitis C transmission. So one of these is correct. Anyone want to guess? Good guess. Guess C. So DAAs are not approved during pregnancy, but they're not absolutely contraindicated. But that was a very good guess. Hep C is associated with higher risk of intrahepatic cholestasis of pregnancy. So we will go through some of this. So Hep C in pregnancy is actually rising. So the prevalence of Hep C positive pregnancies are rising really along with the opioid use epidemic. This is a figure from a paper we published last year, which looked at different waves of the opioid epidemic and also tracked the percentage of pregnancies where there was a positive hepatitis C test. And you could say they've increased over the past 2 decades. Pregnancy itself actually does not appear to negatively impact hepatitis C infection. There's actually a higher likelihood of spontaneous clearance in the postpartum period in people who are pregnant, but Hep C itself is associated with a higher risk of intrahepatic cholestasis of pregnancy. It has been associated with some other adverse pregnancy outcomes, although it's a little unclear if that's from the Hep C or from other comorbidities or confounders. In terms of the risk of vertical transmission, in a recent meta-analysis of, I think, 20 some studies, the pooled risk was 5.8% in people with hepatitis C monoinfection. In people with HIV, that actually increases. So pregnant people with both Hep C and HIV, the pooled risk of vertical transmission was 11%. So a minority of individuals, but still, not zero. No perinatal intervention in terms of, elective C-section or other things like that have clearly demonstrated a reduced risk of vertical transmission, and avoidance of breastfeeding is not indicated. We do recommend if there's, cracked nipples and bleeding, to avoid breastfeeding in that sort of scenario until it's healed, to avoid blood exposure. But the breastfeeding itself is not contraindicated. Now, in terms of hepatitis C treatment during pregnancy, we have a small amount of data right now. But what we do have suggests that it is safe, at least the regimens that have been studied, sofosbuvir, litipisphere. So this is a Harvoni. I haven't talked about Harvoni. It's the earlier sort of version of Epclusa, which is not pangenotypic. But there are sort of these case series of pregnant people treated with Harvoni. There's also a series of people treated with Epclusa during pregnancy, and it does appear to be safe and to be effective. We haven't had any published large-scale clinical trial data yet, even though there is an unmet need. There is a multi-center single-arm study of sofosbuvir velpatasvir during pregnancy, the STORK trial. They presented interim results at the liver meeting a few weeks ago, and so far looks very reassuring. There's been 100% SVR among people who were treated, no transmission to the infant, and no adverse pregnancy events. Is a lot of nausea and vomiting associated, so a lot of GI side effects. They are treating in the late second into third trimester. And then there's a study of glecaprevir pibrentasvir during pregnancy underway. So right now, our Hep C guidance says that this can be considered, with a discussion with the patient. There are a lot of potential benefits of treating during pregnancy that I don't have time to go into in the interest of time during this talk, but we really do this on a case-by-case basis. We have treated a few people here during pregnancy at UCSF. There is this sort of just this voluntary registry if you end up treating anybody who's pregnant with hepatitis C, that you could submit your cases, because they're trying to collect more data on this experience. Okay, last special population that I wanted to talk about here is HCC. So last case, 52-year-old man, newly diagnosed HCC, 3 centimeters, segment 7. He has untreated Hep C in genotype 3. He is compensated, so child A, and MELD is 8. So what do you recommend? Do you want to give glecaprevir pibrentasvir for 8 weeks, sofosbuvir velpatasvir plus ribavirin for 12 weeks? Do you want to refer for local regional therapy and transplant eval, and then wait to treat the Hep C until after the liver transplant? Or do you want to refer for local regional therapy and transplant eval, and then see him back in 4 months to start Hep C treatment? This one is tricky, so feel free to take a guess. So I'll tell you what I would do is D. So refer for his local regional therapy, also refer for transplant evaluation, and then follow up in 4 months to start Hep C treatment then. And this is something that we actually did not have guidance for in our Hep C guidelines. This is a screenshot from our ASLD IDSA guidance website. And we have all these special populations here, similar to the ones that I have on the slide. But what is coming with our newest update, which has not been published yet, but it has been approved by both of the governing boards, and we presented this at the liver meeting just a few weeks ago, is that we will have a new section of special populations, and these are people with hepatocellular carcinoma and hepatitis C. And the reason that we added this new section, there's a lot of reasons, but we recognize that this is a group of people that has really been undertreated. People appropriately focus on the HCC, but then forget about the hepatitis C. And there's also a lot of, or I wouldn't say a lot, but there's some nuance in terms of timing of treatment that we thought people would appreciate guidance on. So I'm just going to walk you through what will come in our newest section for the hepatitis C guidelines. As I mentioned, that one of the motivations for this is that there may be special considerations in the timing of Hep C treatment, but our first box recommendation is that the treatment regimen recommendations are really unchanged from those for patients without HCC. So at this time, there isn't sufficient evidence to recommend modifying the duration of the antiviral therapy or adding ribavirin based on HCC history or current HCC. And then when we were thinking about what the recommendations are for treatment, we really separate people into sort of stages of HCC. For someone with early stage HCC, like the person in the case stem, of course, for people with anybody with HCC, expeditious management of the HCC should be prioritized. But for people at the early stage, there's some evidence that suggests that achievement of adequate HCC treatment prior to Hep C treatment might actually increase the likelihood of SVR with the Hep C treatment. There have been multiple observational cohort studies which have shown that there's a lower SVR among people with HCC compared to those without HCC. And when you look deeper into those studies, it's really the people that have active HCC at the time of their DAA treatment that have the higher risk of a DAA failure. So in the past, people typically would treat the HCC, wait for 3 months, see if the patient has achieved remission, and then if they hadn't, do another treatment, and then wait another month, see if someone's achieved remission, and that what that ended up doing was just leading people to not get treated. So what we're recommending now is to just or consider deferring the DAA therapy until after they've had their initial treatment, but you don't have to wait until you've confirmed a treatment response. So that's the one thing that people in my clinic will notice that will be changing with this guidance. Now, advanced HCC is different. We're not sort of necessarily going to try to wait for somebody to achieve remission, and we know that people with advanced HCC now have more effective therapies available to them, and people are thankfully living longer. And multiple studies now show that people with advanced HCC who achieve SVR with the DAAs have improved survival, including studies done here at UCSF. So our recommendation for people with advanced HCC is that they should just undergo treatment for hepatitis C unless they have palliative goals of care that are inconsistent with DAA treatment. Okay, so now in the remaining few minutes, I want to kind of shift gears a little bit and talk a bit about what's new with hepatitis C elimination. As many of you may have heard about, in March of 2023, Francis Collins announced the Biden administration's new national hepatitis C elimination program. And this program has really three main priorities or pillars. The first was to accelerate the availability of point of care diagnostic tests. The second pillar is to provide broad access to the direct acting antivirals. And then the third was really to improve the public health infrastructure to engage, identify, and treat people living with hepatitis C. This was very exciting when it was first announced. It's been, I guess, a year and a half now. The progress that has been made, this bill is sort of under review right now at the Congressional Budget Office, and is being scored. And when that score is released publicly, then we'll kind of have some ideas of the next step in terms of bringing this bill into, seeing if this bill could be passed by Congress. It seems like a lot of hurdles. It's a multi-billion-dollar bill, but we'll see, I guess. I don't have any updates on that. But the motivation for this program is that most people living with hepatitis C are untreated. So even though we have this phenomenal cure that I've just told you about, we're not doing enough to actually cure people living with hepatitis C. And this was a study that was published by the CDC last year, which showed that only 1 in 3 people who've been diagnosed with hepatitis C in the United States over the past decade have been cured overall. So this doesn't include people who don't even know about their Hep C status. And the likelihood of being cured decreases in people without health insurance and younger people, and then in younger people without health insurance. So this was another study looking at the prevalence of hepatitis C in the United States now, and I highlighted in red who are the populations that are most impacted by hepatitis C. And these include the people who are unsheltered or unhoused, the people who are incarcerated. You can see on the right here, this is the RNA prevalence, um, RNA positivity prevalence, and then people who have injected drugs in the past year, as high as 44% actually, RNA prevalence. Um, so when we're thinking about how we could really reach these people living with hepatitis C, I think it's pretty clear that we're not doing a good enough job right now. And part of that is that a lot of people who are affected by hepatitis C are not necessarily being treated in our traditional healthcare system for a variety of reasons. So there's a real need to bring hepatitis C testing and treatment to people and meet people where they are. And we've been doing a lot of work in that regard in San Francisco that I'm happy to talk more about with you. But one thing that's very exciting that will help us bring testing and hopefully treatment kind of outside of the traditional medical settings is that over the summer, the FDA approved the first point of care hepatitis C RNA test. So this is that, this was part of that first pillar of the National Elimination Program, which, as I said, is still in a bill and it hasn't been passed, but that things are still moving forward. So part of the program was to sort of accelerate the diagnostic testing platforms, and we were excited to get this first point of care Hep C RNA test. I see Gloria asked a question, is generic competition helping lower DAA prices and helping with accessibility issues? It's a great question. The DAA prices have certainly lowered, so that has helped, and there's been a removal of a lot of the payer barriers to DAA prescriptions. So like here in San Francisco, we have very few barriers. So we actually have pretty broad DAA access. There are still a lot of, layers to it and some hoops that we have to jump through and some barriers that could be removed, that a national procurement plan that like one that has been proposed would really help, especially when we're thinking about really low threshold treatment models and test and treat models, which I'll talk about in a moment. So just to talk a little bit more about this point of care test, this is conducted on the Cepheid Gene Expert Express platform, this machine here. And it uses capillary blood. So you do a finger stick and then fill this microtainer with the finger stick blood. Then use this pipette that's provided to load that blood into this cartridge, which looks a bit like a printer cartridge. Put that cartridge into the system, and it takes anywhere between 40 to 60 minutes to run, and then gives a result, which is a qualitative result. So basically positive or negative. So it does take a bit of time. So it takes 60 minutes. It's not immediate. But this is, the first time that we have really sort of rapid same day Hep C RNA results that we could provide to our patients. So it's pretty exciting. You can see on this machine, there's 4 different cartridge areas. So this particular one could run 4 at a time. There's another version that can run 2 tests at one time. So this has gotten a lot of us very excited and thinking about whether same-day test and treat now could be feasible. And that is something that the Hep C guidance panel has also been talking a lot about. And in our upcoming update, we will be providing this test and treat algorithm, which is really meant for community-based sort of settings, or settings where this CLIA-waived point of care RNA test is going to be deployed. And so I'll just walk you through this kind of briefly. But what we're recommending is that with the point of care Hep C RNA test, you also do a point of care HIV test, because we want to know somebody's HIV status before treating their hepatitis C. And then if appropriate, point of care pregnancy test. If the point of care RNA, Hep C RNA test is positive, then you want to assess whether or not the patient is appropriate for sort of a same day or rapid treatment versus needs a little bit more specialty consultation. Remember, we're thinking about this sort of algorithm being really outside of a typical clinical setting. So if someone's, DAA experienced, if they have known hepatitis B, if they have liver cancer, if they, have a history of or evidence of decompensation, those are all more special populations and would not be appropriate for same day test and treat. But if the answer is no, and our data in San Francisco at least suggests that the majority of people that would be, serviced with this point of care RNA test would actually uh, fall into this no category, then we recommend testing for hepatitis B surface antigen. That's still very important. And then fibrosis staging, which at a minimum, you would want to get an AST, ALT, and platelet count so that you can calculate their FIB4 score. And the FIB4 alone would be sufficient to sort of rule in or rule out cirrhosis. So you don't have to do other fancy non-invasive testings for fibrosis. This does still require venipuncture, which is still a challenge in many individuals. But everything else you would do, the medication reconciliation to look for drug-drug interactions, the counseling about treatment, you could do all of that same day. The big issue here is that you won't know somebody's hepatitis B status until after you've given them their course of treatment, if you're giving them the same day Mavorite or Epclusa. So that's where there has to be a lot of discussion about the risks of treating hepatitis C in somebody with hepatitis B co-infection without their Hep B being treated, and there needs to be a plan to follow up the hepatitis B result. So if it turns out that their surface antigen is positive, they should get started on Hep B treatment while they're on their Hep C treatment, and then linked to somebody to provide the long-term hepatitis B management. So you could start same day, call them if their Hep B surface antigen is positive to get them, on entecavir, for example, or you could give them the medications and tell them to hold off until you get a call back from us to hear about your Hep B surface antigen. I will say there is a point of care. There's a push to get point of care hepatitis B testing approved also. And once that occurs, this algorithm will be much simpler. So same day test and treat really is now feasible. There are these obstacles that I listed on the slide. The main ones being the phlebotomy for the fibrosis staging labs and for the Hep B surface antigen. And then some other things that we don't need to talk about now, but how would you get a clinician available on the spot to prescribe the DAs, and then sort of to Gloria's point, also like how do you get the same day medication? And especially if you're doing this testing outside of a setting where you have a pharmacy immediately available. I thought for this audience, you'd be interested in hearing a little bit more about what the actual risk is with the hepatitis B reactivation in the setting of DAA treatment. And this was a meta-analysis that was published a couple of years ago, where they looked at this risk in people who are surface antigen positive and surface antigen negative. Among people who are surface antigen positive, who were not treated for their hepatitis B, but were getting DAA treatment, the pooled reactivation risk was 12%. So not a huge number, but certainly higher than we would like to see. So not something that we can ignore. In the people who are surface antigen negative, so these are people who are core antibody positive, the risk is very, very low. And then if you're thinking about, well, what are the chances that the person in front of me is going to be at risk for this Hep B reactivation, meaning like what's the chance that someone has both hepatitis B surface antigen positivity and is living with Hep C? The estimates really range a lot, but the high end estimate for people with hepatitis C who also have hepatitis B is about 6%. And then if you're thinking about people who inject drugs, the hepatitis B prevalence is up to 12%. So again, not a minority, but still something that's important to think about. And there is a black box warning on the DAAs that say that you need to test for hepatitis B surface antigen before prescribing. And then finally, since we're on the subject of hepatitis B, I just wanted to point out that we also have gaps in hepatitis B vaccination in this population. This is a study that was published by Dr. Partida and Khalili, which showed that among people experiencing homelessness who were hepatitis C antibody positive in San Francisco, over a third were still hepatitis B vaccine eligible, so really in need of the Hep B vaccine. And we showed a sort of similar thing in our cohort in San Francisco, where up to 50% actually of younger individuals living with Hep C who reported current injection drug use remained susceptible to hepatitis B. So, something to think about when we're sort of thinking about these models of Hep C care in the community is not only providing hepatitis C care, but also hepatitis B prevention services with vaccination. The second part of the new ASLD IDSA treatment algorithm is the follow-up. If they're a Hep C RNA 12 weeks after completing therapy, so SVR12 is positive, then then we refer to a specialist because this is more of a complicated case than in terms of repeating treatment. If it's negative, they've achieved SVR, and this is where that fibrosis staging is really important, because if they had a FIB4 of over 3.25, then they need ongoing HCC surveillance and cirrhosis monitoring. And then anybody with ongoing risk factors for Hep C reinfection does need to be tested at least annually for reinfection, just to remind you that, even after someone's been treated, they could get reinfected. The last thing that I wanted to point out, because I've been talking about SVR12, is that we do have another update coming to the guidance with this update, and that is that we recognize that there are high rates of loss to follow-up before getting that SVR12 assessment, especially in the populations where we are recommending this sort of test and treat algorithm. And the studies show that there's actually extremely high concordance between the viral load 4 weeks after end of treatment and 12 weeks after the end of treatment. So, if someone has achieved SVR4, they almost definitely will have achieved SVR12. So, especially if they don't have cirrhosis and they are previously treatment naive. So in the new guidance update, we still have SVR12 as recommendation, but we say that SVR4 can be considered as an alternative measure of cure among people without cirrhosis or prior DAA exposure. So there are these other special populations. I didn't have time to go through all of them. Happy to take questions after this or offline. And thank you for your attention. Happy to take any questions.